So again, today we are looking at another obstetric emergency condition, which is cord prolapse. So cord prolapse itself, it means the cord descending down or slipping forward. So this condition, it's a life-threatening condition. It puts the life of the fetus and also the mother at risk. So if it is not recognized early by the midwife, then the life of the fetus, it can be compromised. Then the management of this condition, it depends on the condition of the fetus, whether the baby is alive or maybe it's dead. So let us now look at the overview of the same condition, which is cord prolapse. So we can see there the cord being compressed by the presenting part there. So those are the pictures which shows the umbilical cord or the cord being compressed by the presenting part. So when it comes to cord prolapse or cord presentations, we have got types of cord presentations where we have got the same cord presentation itself. So you define cord presentation as it's a condition where the umbilical cord lies in front of the presenting part when the membranes are still intact. That's how we define cord presentation. Then when it comes to cord prolapse, cord prolapse is just a condition or an obstetric emergency where the umbilical cord lies in front of the presenting part while membranes have ruptured, or when membranes have ruptured, then it can be even visualized in the vagina or outside the vagina, which is on the valve. Then we have got also cord presentation or cord prolapse. Also cord prolapse, it's when the same umbilical cord lies just by the side of the presenting part or alongside the presenting part. It's next to the presenting part. Then the other thing that we have to know, the other type of cord prolapse is overt cord prolapse. So overt cord prolapse, it's when the umbilical cord presents in front of the presenting part. It's when the umbilical cord presents itself in front of the presenting part. That's overt cord presentations. So I've got cord presentation, cord prolapse, or cord prolapse, then also overt prolapse. Then how do we differentiate now when it comes to cord presentation and cord prolapse? How do we differentiate when it comes to cord presentation and cord prolapse? So we'll look at we'll differentiate the two using two features, which is the position and also the state of membranes. So when it comes to the state of membranes in cord presentations, normally it is diagnosed when the membranes are still intact. But when it comes to cord prolapse, it is even visualized or felt on the vaginal examination when membranes have ruptured. But when it comes to the position, you find that in cord presentation, the cord lies in front of the presenting part, or it lies in between the presenting part and the cervix or the intact membranes. But when it comes to cord prolapse, the same umbilical cord lies in between the presenting part, and also it can even be visualized in the vagina or outside the vagina, which is the vulva. So that's how we can differentiate the two, whether it's cord presentation or cord prolapse. So the same cord presentation, in short, it can lead to cord prolapse if it is not managed adequately. So now let's look at what risk factors can lead a woman to have a cord presentation. What are the predisposing factors of cord presentations? So these predisposing factors, will classify them in three classes. So look at the maternal causes. What can predispose to cord presentation when it comes to maternal causes. Then we'll look at also the fetal predisposition and also the placenta predisposition. So on the what we need to understand basically when it comes to cord presentation, cord prolapse, anything which can cause ill fitting of the presenting part is a predisposition. Anything that leaves room in the pelvis, adequate room for for the for the cord to slip in, then it is a predisposition. So without wasting much of the time, let's go direct to the maternal causes. So one of the predisposition, it's CPD. Example of those with CPD, we can say contracted pelvises. So women with contracted pelvises, they 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 cause ill fitting when the presenting part wants to engage. So if the presenting part fails to engage, meaning it leaves a space or room which predisposes that umbilical cord to slip in and present itself first, or to lie in front of the presenting part. So even in the same CPD, what can cause CPD? Again, you can talk of those who have got spinal injuries or spinal anomalies. Those they tend to reduce the normal diameters of the pelvises. Then you can talk about polyhydramnios. So women with polyhydramnios, you'll find that they have excessive amniotic fluid, such that the engagement is impaired for the fetus. So you find that the presenting part of the fetus will be just ballotting. So descent will not take place, such that it is predisposing the 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 cord to slip in front, or to lie in front of the same presenting part. Another maternal cause that we can talk about is grand multiparity. Women who have born a number of babies, you find that their abdominal muscles, they are relaxed, such that it gives enough room for the fetus to move around, which can cause even unstable lie. So if there is frequent changing of position in utero of the fetus, it predisposes the woman to have cord prolapse in such a way it gives chance for the same umbilical cord to lie in front of the presenting part. But when those membranes rupture, then if it prolapses in the vagina, then it becomes a cord prolapse. Then enough now of maternal causes. We can now look at the fetal causes. Fetal causes, we can talk of prematurity, because of this the small mass, because that premature babies, they tend to have the 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 mass of them, they present more like they are small. They are small. So if they are small, they will give room for the cord to slip in front of them. They give um, room when they want to engage. They will engage normally, but there will be some spaces which will be left, such that they are which is going to predispose the same woman to have a cord presentation. Then the other predisposition or under fetal causes, we can even talk of malpresentation, such as in breech presentation, in brow presentation, um, even talk of shoulder presentation. These they cause ill fitting of the same presenting part, such that it predisposes the woman, or it predisposes the cord to lie in front of the presenting part and presenting with cord presentation. Then you can even talk of malpositioning, such as in OPP. In OPP, they can be ill fitting of the presenting part as well, predisposing the cord to slip in and find its way in the vagina. Then the other predisposition, we can even talk of long umbilical cord. So if there is a long umbilical cord, or if the cord length is long, then it predisposes it to lie or to present first in front of the presenting part. You can even talk of fetal anomalies, or congenital abnormalities like hydrocephalus, because there is accumulation of fluids in the fetal head. It will now present with large diameters, such that it will create CPD as it tries to engage in the pelvis, in the pelvis, such that there will be ill fitting of the same presenting part, and predisposing the umbilical cord to lie in front of the presenting part. So those are some of the uh, predisposition under fetal causes. You can even add locked twins. So in locked twins, or conjoined twins, or Siamese twins, uh, they cause ill fitting of the same presenting part. If there is ill fitting of those presenting part, there is space in between the around that pelvis, which causes a predisposition for the same umbilical cord to lie in front of the presenting part. Even you can even talk of multiple gestation. It's also a predisposition of cord presentation. So enough now of the predisposition under fetal causes. Let's talk of a few under placental causes. You can even talk of placenta previa, like in marginal. You find that it in marginal placenta previa, the cord is predisposed to lie in front of the presenting part. Then you can even talk of velamentous cord insertion, because the placenta is inserted at the edge, so it's more like elongates because it is inserted at the edge, leading to cord presentation as it lies in front of the presenting part. So those were some of the uh, predisposition when it comes to cord presentation. Now let's look at now on the brief management when it comes to cord prolapse, as the cord presentation has complicated itself to cord prolapse. So when it comes to management of cord prolapse, our aim of the management is to relieve pressure. So as you manage these women with cord prolapse, you have to make sure that there is no compression of the presenting party on the cord. The other aim that we target as we manage these women with cord prolapse is to find out whether the fetus is alive or dead. If the fetus is dead, then there is no need of emergency management. Everything becomes normal. The woman is left to deliver spontaneously. Then the other aim when it comes to the management, you have to deliver as soon as you have to let the woman deliver as soon as possible if the fetus is alive. Then the management of cord prolapse depends on the cervical dilatation. It depends on the cervical dilatation. So remember, for you to diagnose cord prolapse, one, you might be doing a vaginal examination, or maybe it was visualized when the membranes ruptured, or it was visualized um, just on the vulva or in the vagina. So the best prolapse is diagnosed on vaginal examination. So as you do your VE, uh, our normal findings, they should be gotten, but find that in cord prolapse there will be pulsation of the umbilical cord when membranes have ruptured or in the absence of the membranes. So there will be pulsation of the um, of the of the umbilical cord. So as you diagnose, if you have diagnosed that this is cord prolapse, you need to shout for help so that you mobilize some other medical aids so that they are going to help you in the quick management of this woman. You work as a multi-sectoral collaboration. You work together so that this woman is helped as quickly as possible. The delivery is done as quickly as possible. So as you diagnose this condition, being an obstetric emergency, you need to call for help. So as you call for help, you don't remove your hand in the vagina. Don't remove your hands in the vagina. So as you call for help, you shout like cord prolapse in room 2 labor ward, cord prolapse in room 3. You need to be specific because you can't just shout cord prolapse with there may be different rooms, yeah, depending with the facility setup. People that you have called for help, they will start searching where the same cord prolapse is. So if you are specific, meaning there will be no time wasting. People will just come direct in the room where there is cord prolapse. So as you shout what's the emergency or about. So cord prolapse in the labor ward, cord prolapse in room 2 antenatal ward. So that people they are specific, they know what they are going to manage or what they have to carry as they go to attend to such women. So as you shout for help, your hands should be in the vagina. So there in the vagina, you have to make sure that you make a fist so that we try to really to relieve pressure on the cord or the compressed umbilical cord. So if you make a fist, you target in pushing the presenting part away from the cord or even up to the to the pelvis there, to the brim of the pelvis, so that there is no compression. Remember, if there is compression there, there is impaired gaseous exchange. So meaning the fetus is going to become hypoxic, or there will be anoxia, which is going to lead to intrauterine and fetal death if not we relieved as quickly as possible. So you try by all means, you push the presenting part higher in the at least up to the pelvic brim so that there is no compression. So as you push that presenting part, you make sure that you get your Fowler catheter. You catheterize this woman. Then you pump in at least a normal saline of maybe 500 to 1,000 mils. Then you clamp that Fowler catheter to just prevent draining or the drainage of the same saline. Because what we are trying to do basically is to create an obstruction so that we impair the descent. So if you push that presenting part, the other mobilized health personnel, they can even help you to catheterize, then pump in normal saline or sterile saline, at least 500 to 1,000 mils, then clamp the same Fowler catheter to prevent draining of the same pumped saline. By so doing, you are creating an obstruction so that descent is impaired. Then, if the cord is visualized in the vagina, or the cord is visualized on the vulva, how do we handle the cord? You need to get your sterile gauze. We use the sterile gauze to handle the prolapsed or the visualized umbilical cord in the vagina. So that we are going to weight the same sterile gauze. Then we use the same weight sterile gauze to handle the cord. But what we use to weight the same sterile gauze, we use normal saline. So you can get that normal saline, you weight those sterile gauze, then that's when you can touch or handle the prolapse cord as you take it in or take it back into the vagina or higher in the pelvic brim. So the reason why we are handling this cord with the sterile gauze, then which are weight with a normal saline, it's we are trying to prevent spasms of the cord. So if the cord is just handled like this, then there will be spasms of it, which is going to cause fetal anoxia, as it leads to intrauterine and fetal death, because the gaseous exchange there is impaired. So if it is prolapsed and it is visualized in the vagina, use the same mentioned interventions as you push the presenting part higher and put the same cord in the vagina. Then put the woman in the knee chest position. So if you put the woman in the knee chest position, you are using gravity there. So that gravity is going to help to push the the presenting part backward, so that it prevents or it avoids compressing on the umbilical cord. So as you do your interventions, this woman should be in knee chest position, so that the pressure is relieved on the prolapsed umbilical cord. So the all the interventions that we are going to do, they are done concurrently, like in a short period of time. Then what you can do next, there and then, give her psychological care, because this woman is wondering what is happening to her, seeing different or a number of health personnel attending to her. So give her psychological care. Let her ask the questions that she can want to know about. So answer them accordingly. So as you give psychological care, explain about the mode of delivery. If the cervical dilatation is still in the latent, I mean in the first stage. If she's not fully, meaning the the mode of delivery of this woman, it's cesarean section. It's indicated there and then. So as you give her psychological care, you explain about the consent form, then the need of signing that consent form. So you let her sign the consent form. Then, based on observation, if there is fetal distress, remember, after just diagnosing this condition, these women are put on CTG, so that there is continuous monitoring of the fetal heart. If there is compromise due to the same compression on the cord, then put this woman on O2. So if there was compromise in the fetal condition, you have to resuscitate, like putting the woman on O2, then making sure that the fetal heart uh, is is not in or is not bradycardic or tachycardic. So that oxygen is going to help to both the mother and the fetus who is hypoxic. Then make sure we cannulate these women. At least we can even commence fluids like normal saline, just to act as a PPH prophylaxis. So before even commence those fluids, collect samples. Those samples should be sent as quickly as possible to the labs. So the same samples, investigations that we can do, or the samples that we can collect for, it's HB estimation. Then you can even collect samples for grouping, cross-matching. Those are samples they should be gotten as you cannulate these women. Then you commence the mentioned fluids. Then you prepare this woman, like physically, where you put the woman on new oro. You even catheterize, since we had even catheterized already. So put the woman on new oro. Then label. Don't take the patient to theater without being labeled. We are just preventing the misoperation. We find that instead of them doing a cesarean section, they are going to do laparotomy, a different procedure, because the indication or the right procedure was not labeled. So label these women. For example, what we label is the name of the patient, the age, the parent, the gravid, even the type of operation that she's going there for. Then you can even remove all cosmetics, like remove whatever that is artificial on her body. For example, these nail polishes, the rings, the earrings, artificial teeth. Those are some of the mentioned things, or artificial cosmetics, or the cosmetics. Remove all cosmetics here. Then make sure that there is reload given to these women who are going for surgery. So you need to load the prescribed at least antibiotics. The best is ceftriaxone. We give it IV 1 gram. Then from there, do some observation as you prepare to refer this woman for OT. So do some latest observations. But remember, after this cord prolapse was diagnosed, theater needs to be informed. So at this point, we expect the theater people, the theater staffs, they are already been informed about the case that you are having. So as you, after doing observations, document whatever findings you have, the latest findings. As you escort this patient now for OT, make sure that you carry the patient's file or documentation on the patient, like the laboratory results, everything they need to be carried. Then give the handover there to the theater nurse or the theater people or staff. As you give handover, you mention, for example, the patient's name, the age, the gravid, the parent, then the procedure that she has gone there for, then the indication of the same procedure, then the pre-medication given, and the latest vitals, or the latest observations. Then as you after giving the handover, you need now to wait. You start preparing now, receiving a baby from cesarean section. You prepare your resuscitative equipment. You make sure that all the resuscitative equipment, they are available, they are within reach as you receive the baby. After the baby has been extracted from a mother's uterus, make sure that the baby is okay. If there is need for resuscitation, you resuscitate there and then. So the delivery or the indication of cesarean section when it comes to prolapse, it depends with the the fetal compromise. If there is fetal distress, then automatically it becomes an indication for cesarean section. But if the cervical dilatation was 10 centimeters, meaning they can be just an assisted delivery, like you can even use vacuum, you can even use forceps delivery. But if the cord prolapse is diagnosed in the first stage, the better option or the standard delivery for these women with cord prolapse is cesarean section. So we have come to the end of our discussion for today.